Hello everyone, welcome to Midi Cuisine. Today we are going to discuss about a very important general medicine topic, that is stroke. This is our first official video regarding medical topics on this YouTube channel. So if you like it, please subscribe the channel and like the video, share the video and support us. The stroke is a serious medical emergency state where we need medical intervention on urgent basis because we may lose body functions like speech, body movements if we don't do that. The term stroke is used according to some people because the patient is struck by the medical symptoms. They occur all at once. The patient is normal when all of a sudden the symptoms occur. Now, moving on to the today's topic, the outlines include understanding stroke and its types, the cerebral blood supply. This is really important regarding a stroke. If you want to understand the stroke, if we say like, and clinical presentation, the clinical presentation depend on which area of the brain is deprived of the blood. So for that you need to remember the blood supply of each part of the brain. That is really important to understand today's topic. And at last we will talk about the management of stroke, the investigations, the medicines being used, the different surgeries we will discuss later in this video. By definition, it is a cerebrovascular accident. It is a cerebrovascular accident. A cerebrovascular accident may be ischemia, may be hemorrhage, which causes focal neurological deficits lasting for more than 24 hours. The three things: cerebrovascular accident causing focal neurological deficits for more than 24 hours. The 24-hour time mentioned here is very important because it will help us to differentiate between stroke and TIA, transient ischemic attack. And transient ischemic attack, the symptoms, the focal neurological deficits occur, but they resolve before the 24 hours, before the 24-hour time is completed. So the TIA and stroke should be differentiated. Question arises why it is so much important to differentiate between stroke and TIA, because the management differs. If we are dealing with stroke, the management is something else. If we are dealing with TIA, the management is something else. Besides stroke and TIA, two other terminologies are being used, but now they are become obsolete. The REND, reversible ischemic neurological deficits, and PREND, the prolonged reversible ischemic neurological deficits. The reversible ischemic neurological deficits, the REND, the symptoms, they occur for more than 24 hours but less than 3 days. The prolonged reversible ischemic neurological deficits, they occur more than 24 hours but less than 1 week. So up to 5 days, 6 days, 7 days, more than 3 days, but less than 1 week. So these terminologies, the REND and PREND, they are obsolete now. So moving on to the types of stroke, there are two major types of stroke. One is ischemic, one is hemorrhagic. The ischemic stroke accounts for 80% of cases. Hemorrhagic stroke accounts for 20% of cases. In ischemic stroke, there is a thrombus or embolus, which causes occlusion of one of the arteries of the brain, thus depriving the brain tissue of oxygen and other nutrients. And hemorrhagic stroke, most commonly, there is an aneurysm, which is outpouching of the blood vessel, which ruptures, causing bleeding into the brain parenchyma. So this is some pathophysiology of the ischemic and hemorrhagic strokes, which we will discuss in details later in this video. So the clinical presentation of stroke, depends on which area of the brain specifically is deprived of oxygen. So for this we need to understand the blood supply of brain properly and the circulations of brain properly. So the brain brain blood supply is divided into anterior circulation and posterior circulation, and posterior circulation, which together make the circle of Willis, the beautiful circle of Willis, which lies in the subarachnoid space in the base of the brain. The circle of Willis anteriorly is formed by the anterior cerebral arteries, the middle cerebral arteries, and posteriorly it is formed by the posterior cerebral arteries and the vertebral arteries. These are the two vertebral arteries which together form the basilar artery. This is the beautiful circle of Willis which supplies blood to the brain. This comprises of anterior circulation and posterior circulation. The anterior circulation consists of anterior cerebellar arteries and metacerebellar arteries, and posterior one is formed by the vertebral arteries together forming the basilar artery, which ends in posterior cerebellar artery. This is the internal carotid artery which continues as middle cerebral artery. This is the anterior cerebral artery, and these are the two anterior cerebral arteries, and this is the anterior communicating artery. Posteriorly, these are the two vertebral arteries. They together form the basilar artery, and the basilar artery ends into two posterior cerebellar artery of the two opposite sides. This is the superior cerebellar arteries, cerebellar arteries, and there is also inferior cerebellar artery. This is the inferior cerebellar artery, which is ICA, which is the direct branch of the basilar artery, while the posterior inferior cerebellar artery is branch of the vertebral artery. So this is the circle of Willis, which is really important to understand, and to understand this stroke, this whole topic, which consists of anterior circulation and posterior circulation. So as we said, that the clinical presentation of stroke depends on which area of the brain specifically is involved, or which artery of this circulation is involved, which supplies this specific area. When the anterior cerebral artery is involved, there is contralateral weakness and sensation loss more in the leg as compared to the upper extremity, and there is also confusion, behavioral disturbance plus urinary incontinence. There is a vague method of remembering all these symptoms, that I am confused and I wanna kick you, but I can't because my leg is weak, so I pee on you. There is contralateral weakness plus sensation loss in the leg more as compared to the upper extremity, like in the arm. Plus there is confusion, there is behavioral disturbance plus urinary incontinence. So this is the mnemonic to remember the signs and symptoms that occur when there is involvement of the anterior cerebral artery. When there is involvement of the middle cerebral artery, there is contralateral hemiplegia. The arm and the leg is involved. One side of the body is involved. There is contralateral sensation loss, the hemisensory loss, both in the upper and lower extremity, and there is homonymous hemianopsia. Like when same side of the both visual fields is lost, when the right side of the both visual field is lost, or when the left sides of the both visual fields is lost. This is called homonymous hemianopsia. There can be aphasia when the dominant hemisphere is involved. So when the dominant hemisphere is involved, this can cause aphasia. So middle cerebral artery, dominant hemisphere is involved, there is aphasia. Inability to comprehend the speech, inability to understand speech. This is called aphasia. And also there is two types of aphasia: sensory aphasia and motor aphasia. If you cannot understand speech, or you cannot produce proper speech, you cannot talk properly, this is also aphasia. So this is a separate topic of aphasia. Sensory aphasia and dominant aphasia. So the Wernicke's area, the Broca's area, which we will discuss in some other lecture. When there is involvement of the posterior cerebral artery, as you know, the posterior cerebral artery supplies blood to the occipital lobe, to the cerebellum and brainstem. So when the main posterior cerebral artery is involved, there is contralateral homonymous hemanopsia. So when the right side posterior cerebral artery is involved, there is loss of left sides of the two visual fields. Plus there is agnosia, which refers to inability to recognize objects and persons. So when there is involvement of the penetrating branches of the posterior cerebral artery, there is cranial nerve number 3 palsy plus contralateral hemiplegia, which is called Weber syndrome. So Weber syndrome is cranial nerve number 3 palsy plus contralateral hemiplegia. So this Weber syndrome occurs when there is involvement of penetrating branches of the posterior cerebral artery, or when the penetrating branches of the posterior cerebral artery is involved, there may be Weber syndrome or Benedict syndrome, in which the contralateral hemiplegia, besides contralateral hemiplegia, there is contralateral ataxia. Cranial nerve number 3 palsy plus contralateral ataxia is Benedict syndrome. Cranial nerve number 3 palsy plus contralateral hemiplegia is Weber syndrome. So moving on to the basilar artery involvement, when the perimedian branches of the basilar artery is involved, this causes locked-in syndrome, where there is involvement, where there is paralysis of all the muscles of the body from head to toe. They become paralyzed. So quadriparesis. So both the upper extremities and both of the lower extremities, they are paralyzed. This is quadriparesis, except there is intact vertical movements of the eye. So there is intact vertical movements of the eyes, and vertical movements of the eyes, they are intact in locked-in syndrome. So locked-in syndrome can also occur in hyponatremia. When we correct hyponatremia, we give sodium. So the rate of correction should not exceed 0.5 milliequivalent per hour. When we exceed this rate, this can cause central pontine myelinolysis, which can also cause locked-in syndrome. So this is just for information. So when there is involvement of the posterior inferior cerebellar artery, this causes Willenberg syndrome, where there is ipsilateral loss of facial sensations and contralateral loss of body sensations, plus ataxia, dysphagia, and dysarthria. The ataxia is contralateral. And remember, the pica involvement can also cause Horner syndrome, but most commonly it will cause Willenberg syndrome. Also remember, the pica is not a direct branch of the basilar artery, rather it is a branch of vertebral artery, while the ICA, the anterior inferior cerebellar artery, is direct branch of the basilar artery. Concept called FAST method, which is used to assess the condition of a person. If you suspect the person for having a stroke, you can ask to smile. You can ask the patient to smile if one side of the face is drooping, or if you ask to raise his or her both arms and one arm is dropping, or the speech of the patient is slurred. You don't have time. The patient is more likely to have a stroke, and you don't have time. The patient needs urgent medical care, call an ambulance. So moving on to the management of stroke. You are doing your duty in emergency and a patient is presented to you and you suspect the patient for having a stroke because the symptoms are aligned with the stroke. So you order first, you order non-contrast CT because you want to exclude the hemorrhagic stroke. It will decide your management, because if it is hemorrhagic stroke you will do something else. If it is ischemic stroke you will do something else. So the first thing you will order non-contrast CT. If it is positive for hemorrhage, this is a contraindication, an absolute contraindication of thrombolytics. You put the patient on observation only. You strictly control the BP of the patient, where your goal should be the mean arterial pressure should be less than 110. So strictly control the BP when there is hemorrhagic stroke. Because we want to minimize the intracerebral hemorrhage. When the patient becomes stable and you locate the source of hemorrhage, and if this is there is aneurysm, you can do surgical clipping of the aneurysm to make and to block the blood flow through this aneurysm. And if there is AV malformation, you can actually surgically remove this AV malformation. But if the AV malformation is very large in size and lies deep in the brain tissue, you cannot remove it surgically. And you can also remove the hemorrhage through a burr hole, but this should be minimally invasive. So when there is hemorrhagic stroke, the CT is positive for hemorrhage, you cannot do anything of this patient. You simply observe the patient. You simply control the patient BP, and when the patient becomes stable enough, you can surgically intervene then. And the surgical options you have is surgical clapping of the aneurysm and surgical removal of the AVM when it is small and lies superficially. And also you can remove the hemorrhage through a burr hole. So there is another concept here. A patient is presented to you, you do CT, non-contrast CT, but when a patient is presented to you within 30 minutes of onset of symptoms, the CT is sensitive for blood, and MRI is sensitive for fluid in the brain, like water in the brain. The cells become edematous. When there is ischemic injury to the cells, they become edematous, the area become edematous. So you can pick it through MRI. But here the 30-minute time and 30 minutes, there is no sufficient bleeding which can be packed by the CT. So you directly go for MRI then, because the CT is not so much sensitive to pack very little amount of bleeding at the brain. So you directly go for MRI, because there is a high probability that the CT would become negative when the patient is presented within 30 minutes of onset of symptoms. So remember this when you are managing a patient with stroke. Now we said that when the CT is positive, there is hemorrhagic stroke. This is an absolute contraindication of thrombolytics like TPA. So here we are going to discuss about the contraindications of thrombolytics. There are absolute contraindications and there are relative contraindications. Relative contraindication mean the doctor look the benefits versus the risk. If the benefits overweights the risk, the doctor use the thrombolytics. So there is comparison of benefit and risk. When there is overweighting of one side, you can look at the scenario. So the absolute contraindications include hemorrhagic stroke, the previous history of hemorrhagic stroke or present hemorrhagic stroke, as we said minutes ago. When history of ischemic stroke in the past 3 months, history of intracranial hemorrhage, subarachnoid hemorrhage, etc., intracranial neoplasm or AV malformation, you cannot use thrombolytics, and the BP is greater than 180 by 110 mm of Hg. So in hemorrhagic stroke, we discussed, you put the patient on observation, you strictly control the BP. So you strictly control the BP. So in hemorrhagic stroke, when the BP is greater than 180, also in ischemic stroke, when the BP is greater than 180 per 110 mm of Hg, you cannot use thrombolytics. So you control the BP first, then you give thrombolytics, and this we will discuss this scenario later in this video when we will manage the case of ischemic stroke. So platelets less than 1 leg per millimeter cube and anticoagulant use with INR greater than 1.7. The relative contraindications include MI in past 3 months, GI gastrointestinal and gastrourinary bleeding in past 3 weeks, and major surgery in the past 2 weeks, and pregnancy is also considered a relative risk, a relative contraindication to use of thrombolytics in case of a stroke. When the non-contrast CT comes out to be negative, you go for MRI, and this should be a specifically diffusion weighted MRI. The diffusion weighting is an MRI technique which is used to increase the sensitivity of MRI for edema in the brain. So you confirm ischemic stroke through MRI. You plan for thrombolytics considering time and contraindication. When the time is appropriate, means the patient is presenting to you within 3, 4, 5 and up to 6, 8 hours of onset of symptoms, you can give thrombolytics and they can dissolve the clot inside the vessel. And if the time is not appropriate, there is like 10, 12, 13 hours, the thrombolytics are of no use here, and they cannot dissolve the clot because it is stabilized by fibrin, and the stabilized clot is not dissolved by the thrombolytics anymore. So considering time and contraindication, you can plan for thrombolytics. And if you give thrombolytics after 24 hours, put the patient on aspirin, and if the patient is allergic to aspirin, you can use clopidogrel. And if the patient is already on aspirin, you use dipyridamole. You cannot combine aspirin with clopidogrel. You simply switch between these two, and you add dipyridamole to aspirin, and if the patient is already in aspirin. So this is another concept regarding the management. Now, in management of ischemic stroke, there is a concept called permissive hypertension. 60% of patients presenting with ischemic stroke, they actually have hypertension. When you check their BP, it is like 200, 210. So interestingly, you will not decrease the BP. You will allow the BP to be raised like above 180, above 185. This is called permissive hypertension. Where you allow the BP of the patient to be above 180 or 185 mm of Hg. This is called permissive hypertension. Why we do that? The question arises, why we do that? Because there are collaterals which are supplying the deprived area, which delivering oxygen to the deprived area of the brain, which is deprived of oxygen and blood. So these collaterals, they depend on the blood pressure. If the blood pressure is sufficient, like around about 180 185, the circulation can feed these collaterals, which can further supply blood to the deprived area. So to support the collaterals, we allow the BP to be about 180 or 185 to support these collaterals. Remember, in hemorrhagic stroke, we don't do this. We strictly control the BP to minimize the hemorrhage. In management of ischemic stroke, there is concept of permissive hypertension. Remember this. Examiners love to ask this concept in management of stroke. Now we have talked about permissive hypertension, but remember, after you check the BP, if it is around about 180 or 185, you give thrombolytics. But if it is increased like 210 to 15, first you decrease it to 180 or 185, then you give thrombolytics, because in absolute contraindications we have studied that BP greater than 180 or 185, this is an absolute contraindication of thrombolytics. So remember this, first you decrease the BP to 180 185, then you give thrombolytics. Now let's discuss about some other investigations beside CT scan and MRI. So to know about the etiology of the stroke, why the stroke has occurred. To know about the etiology of stroke, we will go for ACG to exclude AFib, atrial fibrillation, as a cause of stroke, and echocardiogram to exclude the patent foramen veil as a cause of stroke, and we will do carotid duplex to see carotid artery disease. And if the carotid artery is 70, there is 70% occlusion or greater than 70% occlusion, we will do carotid endarterectomy. And if there is 60 to 70% occlusion and the patient is a man and asymptomatic, we can also benefit from the carotid endarterectomy. There is simply a rule: greater the risk, greater the benefit. If the patient is a woman, she has lesser risk of a stroke. So the benefit of endarterectomy in this patient will be lower, because there is decreased risk of the stroke. And beside carotid endarterectomy, for carotid artery disease, we have other options like carotid angioplasty and stenting also. But if the occlusion is greater than 70%, we can benefit from carotid endarterectomy more as compared to carotid angioplasty and stenting. There is one interesting piece of information that if there is 100% occlusion in a carotid duplex, what will you do? You cannot perform surgery, because if there is 100% occlusion in a carotid duplex, there are collaterals which are supplying the deprived area, the region where there is blood coming from the artery. The region which is supplied by the occluded artery will be supplied by the collaterals. So you augment these collaterals, and you medically manage this patient when there is 100% occlusion. This is an important piece of information which I wanted to deliver you. So if there is greater than 70% occlusion, carotid endarterectomy, and the other options are carotid angioplasty and stenting. And if there is 60 to 70% men and asymptomatic, you can also do carotid endarterectomy. Here is a fun question. A patient is admitted due to ischemic stroke. The symptoms are relieved, but all of a sudden the symptoms start getting worsened. What will you do to the patient? Patient is admitted due to ischemic stroke. The patient is stable. The patient becomes stable. All of a sudden, the symptoms become worsening. What will you do? You order. The answer is you order CT. You repeat CT because there is a high probability that the ischemic stroke is converted into hemorrhagic stroke, and the worsening of symptoms is a classical description of hemorrhagic stroke. So you can only differentiate between ischemic stroke and hemorrhagic stroke through radiology, but clinical differentiation you can vaguely differentiate clinically the ischemic stroke from hemorrhagic stroke by seeing at the symptoms. If the symptoms are worsening with time, there is high probability that the stroke is of hemorrhagic type. So this is another piece of information. So we studied that to exclude AFib as a possible cause of stroke, we will do ECG. But what will we do if ECG comes out to be negative? We go for 24-hour Holter monitor. Why we do this? Because there is a probability that at the time of doing ECG, the AFib may be absent, but at some other time of the day, it can reoccur. So we continuously monitor the electrical activity of the heart for 24 hours non-stop to exclude the AFib, because at the time of doing ECG the AFib may be absent, but in reality AFib is present, but at the time of doing ECG it is absent. So we go for 24-hour Holter monitor. This can be a favorite question for your examiner to challenge your knowledge, and they ask, what if the ECG is negative but there is a strong suspicion of AFib? You go for 24-hour Holter monitor. Okay, we are now into the management of transient ischemic attack, TIA. First question, is transient ischemic attack needs to be managed, needs to be treated, and if it does so, why? So the answer to the question is yes, because if a patient has transient ischemic attack, he is at increased risk of stroke in the next few days, 8% of risk in the next 30 days, and the patient is having 10% risk in the next 90 days. But most of the cases of stroke following TIA occurs within the next few days, like 3 days, 4 days, 5 days. And regarding the management of transient ischemic attack, we go with aspirin plus statins, the lipid lowering drugs, and counseling of the patient is really important in the management of transient ischemic attack and to minimize the risk of stroke in the following days. Regarding BP control and blood sugar control and smoking cessation, these are the 3 cornerstones of counseling and the management of transient ischemic attack. So this was something about stroke, which is a very important general medicine